All right, so this may be the smallest turnout to a town consortium meeting that we've ever had. And there was even free food, so I'm not sure what to do next time around for people to show up. But why don't we just go around the room so that we know who's in the room. We'll start in the back corner, Deb.
Deb Chapman, trustee at large.
Wayne Clark, new Frank trustee. Stuart Barker, Jamaica trustee.
Personnel Director of Special Program.
Bob Ozer, Dempsey Board.
Mark Schauber, the EMS fund.
Emily Beer from Brookline. Mary Old, Chesterfield, New Hampshire, board member.
And I'm Fran Shippey, also from Chesterfield.
Thank you for having Chesterfield represented. We appreciate you being here.
Double
Represented. You guys are pulling the weight for the whole 14 towns. So go easy on me with all of your difficult questions. So it should make this pretty quick. Just a little bit, I always like to start with the history before we go to the future. And we're rolling into our 60th year, which is pretty exciting. I will tell you, there's not a lot about EMS that's the same as it was 60 years ago. And if you've been around the open house and kind of looked at some of the technology and the ways that we do things, you'll notice it's rapidly evolving as we move into the future of EMS. And we'll talk a lot about that here in a minute. The important component is our mission has not changed. So we are still here taking care of the people in the 14 towns that we serve and supporting our staff and the area with education. So our mission is still solid and we're still actively working on it every day. We do serve 14 towns as our primary 911 coverage in about 475 square miles. We're doing that out of our 2 stations, one in Brattleboro, one in Townsend. So the end of our fiscal year, we just ended 1st of July, 5,089 calls. So that's a decrease from what it used to be when we had 15 towns, but an increase year over year from where we were at. Again, about 475 square miles, 300,000 miles traveled over the last year. For those that are keeping track of ambulances, that means that we need an ambulance about every 10 months in order to keep up with the mileage that we're currently doing. So we're running a bunch of ambulances, staff vehicles, technical rescue equipment, boats, very similar to what we have in the past. Doing that all out of 3 locations, one being here at our training academy, and then our stations in Brattleboro and in West Townsend. So we continue to work hard to kind of set the bar and set the bar high for EMS as well as our technical rescue group. In the last year, we got to send our technical rescue group out to South Bend to receive an award for rescues done during the flooding in 2023. We're also very proud of our Mission Lifeline Award, one of very few services in New England to end up with a gold Mission Lifeline. And that award is given out for services based on their cardiac and stroke care. And it's a comprehensive award. It's not only the emergency response, but in partnership with the hospital, the overall cardiac and stroke care. So we have ambulances. Fun update for the board members that are in the room. We ordered new ambulances in 2021, March of 2021. And those ambulances did not arrive post-pandemic. We've had supply chain issues and we've had to source ambulances from other places. Recently I got this photo. They claim this is the ambulance that we ordered in 2021. I got it a couple weeks ago. They tell us that this is our truck, or it could just be somebody else's truck. I have no idea. But I have a picture of what looks like an ambulance that they say is coming in September. The other one is A4, which is outside right now. That truck we actually put into service this week. That will be joining our fleet in the capacity to replace our retreat program truck that puts on a lot of mileage. So we have 2 of these AED trucks coming. One should be here at the end of September, and the second one should be here at the end of December. Outside, I hope you had an opportunity to take a look at some of the Other equipment that we keep out there, so one of our rehab shelters is set up outside with air conditioning. Doesn't normally have a boat inside of it, but right now we're trying to, we've got the boat inside to keep it cool. But those are for large incident command post activity, evacuation, fire scene standbys. We have a whole group of those tents. That's one of 4 that go together to create a small little tent city that we can operate out of. What's not here on site is our rehab trailer. That's actually up at our Townsend office that we support the fire departments with, cooling, heating, as well as monitoring vital signs for those firefighters that are working. We've had a little bit of change in our retreat program this year due to some of the healthcare reform going on in Vermont. We've reduced the hours and we're now operating 8 hours a day, 5 days a week. That's down from last year where we were 7 days a week and 12 hours a day. We don't know what the future holds for specialized mental health transport in Vermont, given the changes in the kind of healthcare landscape, but we'll certainly adjust to meet whatever that need is as the healthcare system changes. So the big news of the year, and there's more news coming around our mobile integrated health program. Unfortunately, the towns that are represented, or the town that's represented in the room, would be the area that we don't actually operate in, because we don't operate in New Hampshire yet. New Hampshire is much more complicated when it comes to mobile integrated health than Vermont. We partnered with BMH, and we're doing a few different programs around around cardiac, CHF, and COPD care, as well as orthopedics. I've got 2 slides. His slides are going in the background, and it's really messing with my head. So our program has enrolled multiple patients in both the orthopedic world as well as the CHF world. Apparently these slides automatically move, and it came through that way. Which is also messing with my head a little bit here. But I think some of the numbers here are pretty impressive, and I'll let Chris go ahead and talk about these from the back of the room. I'll even click back for you.
Yeah, so we started the MIH program in 2023 working with orthopedic patients, particularly with total joints. It's a very, very complicated procedure. It takes a pretty significant recovery. And what we're doing is going into the home and helping provide some supportive care. Education ahead of time, as well as a discharge and then follow-up, which is just an extension of the orthopedic office. We've worked with 250 patients so far already, with really good success. The patients enrolled in our program do significantly better. They go back to the emergency department less and have significantly less readmissions after these surgeries. Last fall, we started up with COPD patients, and we got kind of a panel of some of the sickest patients that Brattleboro Memorial Hospital has to deal with, as well as then we started CHF. And we go out and provide preventative medicine. That's what mobile integrated health is. It's preventative medicine as well as being able to intervene in a different manner than we normally would do on a 911 call. I've got 15 staff members that have gone through training for this program at this point, and it's continuing to grow and build upon itself and is showing some pretty significant cost savings to the healthcare system.
And for anybody that's interested, we'll be having another meeting here on the 12th of August. Secretary of Human Services will be down here, and we'll be doing a specific presentation on our mobile integrated health program. So again, outside you see some of the other things that we have going on beyond the ambulance service. Our water rescue, high angle rescue teams, backcountry rescue. We have a group of about 40 volunteers that travel around the state, into New Hampshire as well, to provide those services should we need them. In the last couple of years, it seems as if the weather patterns that are coming through keep us on our toes. A lot of flood responses. What's interesting is we've kind of seen a shift away from missing people as technology has improved and people have more connectivity in the backcountry. We're seeing less lost people, but we're also seeing more floods. So a lot of focus on water rescue in our world. I thought this is a good quote that came from Mike Cann. We're one of Vermont's MOU teams or flood rescue teams. And our team is the first call every time the state of Vermont has flooding, regardless of whether it's the southern part of the state or the northern part of the state. We're the first team out the door. We provide 2 Type 3 swiftwater teams to the state of Vermont. So VEMSA has got a lot of stuff going on. Every day of the week, we have some sort of program running here, on site, out in the field, and soon to be with our mobile simulation trailer. So advanced EMTs, EMT classes, our first paramedic cohort is now 4 months into their training and education, with our second group of paramedics starting on the 16th of October. So we're now able to train everybody from that initial part of their EMS education all the way through critical care paramedics. As Chris mentioned, we've added a new program, or adding a new program here for training mobile integrated health providers. We're working with the state to be the certifying MyH provider for the state of Vermont. So hopefully we'll be rolling that program out very soon. If you're here, you got a chance to see the trailer. It's outside, super exciting. Having the ability to take these high fidelity human simulators and our talented staff to other places. So we have kind of a thing going on here at the Academy where, we have a very immersive environment. We get people into the lab. We let them experience what it feels like to be an EMS provider under that stress. We can debrief them in a way that is educational, so that they can understand the ins and outs and what I would say the art of EMS really is. The mobile education trailer is going to allow us to take that 2 places. Let us do that continuing education for departments that don't necessarily have access to the same tools that we do. So again, here it's very exciting. It's outside. Going to set up for some scenes now. That's new to us. I already mentioned our paramedic program. Next class starts in October of 2025. We currently have 6 students enrolled. We hope for 2 more. So I think we'll probably hit our targets for the second class at our paramedic program. Here's the press release out for our training classroom. Recent news for us. And now we'll talk about the politics that are going on. So, good thing is I started with New Hampshire, and since New Hampshire is well represented, do you guys know what's going on in New Hampshire with EMS legislation?
Not as much as you do, I'm sure.
So, actually, it's there's some good things and some bad things happening, like around the world. So we won't talk about the national legislation yet, but in New Hampshire, the governor 2 days ago signed an piece of EMS legislation around balanced billing. And something we talked about at our last year's consortium meeting, where the state of New Hampshire, the Ambulance Association of New Hampshire, was looking to set a floor for private insurance carriers. So that legislation started off this year. They introduced a bill to create a minimum payment for ambulance services at a rate of 325% of the current published Medicare fee schedule. It's a move that has happened in about 16 other states so far. There's another dozen states that are in the process. So New Hampshire was probably the 17th or 18th state that has
So is it
passed
good
it.
or bad?
Well, that's good. It's good
Okay.
for patients, and it's also good for ambulance services. Because what it means is that the insurance companies now, private insurance companies, must pay, starting in January, must pay the minimum charge of 325%, or your billed charge, whichever's less.
And what is that amount? What's 300?
I'll
Does it
show you on a
cover-
slide in just a moment. But what it also means is that the ambulance company cannot balance bill the patient. So it's good for the patients and it's good
Okay.
for the ambulance services. Because what was happening in New Hampshire was the insurance companies would simply send you a check for whatever they wanted to.
Mhm.
So it may be a $1,000 bill and they would send you a check for $200, and then the patient would get an $800 bill and they'd be surprised. And then the question was, is the insurance company's problem or is it the ambulance service? And so what New Hampshire's decided is for the next 2 years, they're setting the floor at 325% of the current Medicare rate. The second half of that, which is complicated, and this is where Ellen gets to do all the hard work, is it comes with a whole bunch of requirements for mandatory cost reporting so they can determine if that 325% number is correct. So there's a massive amount of new accounting that we all have to start doing on the 1st of January. And then in January of 2028, they will decide if that number was right or wrong and adjust it after that. So that's what's going on in New Hampshire. So again, that's why I said it could be good. It also creates a fair amount of challenge, and certainly will cause Ellen in our office significant challenges keeping up with the cost reporting. So that bill is, if you want to look it up, it's Senate Bill 245. It was just signed into law a couple days ago. Thursday, actually. So Vermont, we have Vermont board members, not a lot of select board members from Vermont. Vermont has a healthcare crisis. Vermont spends $6.4 billion a year on healthcare for 660,000 people, and that is simply not sustainable. We've looked at reports on our hospital system. They did a study using a firm, and Oliver Wyman came out and looked at all of our hospital systems, made some recommendations, and from that, we have a healthcare transition team working in Vermont, actively redesigning our healthcare system, including reducing services at local hospitals, recommending mergers of services, as well as reducing payments in some areas. So I just put one example up here of hospital cuts, but we've already seen hospital cuts at some of the largest hospitals in Vermont, specifically the UBM Health Network. So with that, there's been a lot of conversation about where does the money go in healthcare in Vermont. So just to put it into perspective, the total healthcare spend in Vermont is $6.4 billion. The total estimated cost for EMS across the entire state is under $100 million. So we are a fraction of the healthcare spend in Vermont. That does not make us immune from some of the changes that are happening in healthcare. It brings us to our EMS bill that passed in the spring of 2024, which is Act 152. That bill directs the EMS Advisory Committee to study EMS in Vermont as it stands right now, looking at things like the cost of delivery, the quality and reliability of our system, workforce development, education, as well as some other pieces of our healthcare system, our EMS system, and requires us to report back to the legislature line level data on every ambulance service and first response service in the state by December of this year. We've been actively working, I chair that committee, we've been actively working on that now for just about a year. We have gathered a significant amount of data. We're currently compiling that data, refining that data, and we will be ready to report back to the legislature on the current state of our EMS system by December. The second half of the bill required us to design a statewide EMS system and a 5-year plan for implementation and goals that needed to be presented back to the legislature by December of 2026. This is a very different conversation than what's happening over in New Hampshire. What does a statewide EMS system look like? What is a statewide EMS system? And those are currently the topics of discussion that are happening at the advisory committee in Vermont. So we are discussing what is EMS. And what we've recently determined, and we'll be voting on Wednesday, is that the definition of EMS in Vermont is very different than what it has been and what it was in 1966. EMS today in Vermont encompasses things like mobile integrated health, specialized transportation, high fidelity training, procedures that were never thought of in previous versions of EMS. When rescue started in 1966, ultrasounds were not in the back of ambulances. EKG monitors and end tidal monitoring It's not even really a thing. Now the technology and the diagnostic testing that we have allows us to do a lot more. It allows the interconnectivity between us and the hospital through our MIH program allows us to have access to patient medical records and get updated information and provide updated information to their providers. So we're discussing what is the definition of EMS, and we're starting off with redefining what that means, and then we're going to define what it means to have a statewide EMS system. That doesn't mean that we're all going to have the same ambulance service provider in the state, but what it does mean is that we need to have a single system statewide that works together to provide services not only for emergencies but also for all of the care that's dependent on patient transport. As our healthcare system shifts, as services at local community hospitals are closed, changed, or modified, those patients are still going to need services. They're just going to need services that come with transportation. So we see it now with many times where we have critical patients that are showing up at our local hospital, whether it's Cheshire or Brattleboro. Services are not available, and we have to take them to either Dartmouth or Connecticut or Hartford or Albany. What we're also noticing locally in our system is that those patients are having to go further and further away because what we would call our definitive care or those level 1 trauma centers don't have the capacity to take the volume of patients that we're sending from our local community hospitals. So what does it look like as we reform healthcare, as we remove services from hospitals? I believe it looks like EMS transporting more frequently and further to specialized care. We don't know that, but that's what we're talking about. That's what's happening in Act 152. We learned in June that the healthcare reform team has a different timeline than the legislature. So we were given, as a committee, the ability to study and work through the meaning, the definition of a statewide EMS system until December of 2026. We've been informed by the Secretary of Human Services that we need to get that work done in the next 6 months, or the healthcare reform team is going to already be putting forward those changes ahead of the timeline that we're on. So we're now trying to accelerate our work and try to get this work done by January of 2026. So we've taken an entire year off the runway that we thought we had to redesign EMS in Vermont. That will have an impact on the way that we do things here. I think it's going to have an impact on every single service around the state, just as the New Hampshire legislation is going to have an impact on every single service around the state as far as the way that we do business. There's been some local things, pressures, and we don't have anybody here from Putney, but local tax dollars are tight, and we can see it with local services or local towns looking at ways to scrounge up dollars, whether that's through billing for EMS or fire calls, or that's through asking for your local nonprofits to make donations to your tax fund. We can see it. We understand that not only is the healthcare market tight, but property taxes are high, and people are certainly feeling the pressure. So we're seeing the state, we're seeing the local pressure, we're seeing the federal pressure from the, whatever you want to call it, big beautiful bill. There was plenty of impact on EMS. Keep in mind that our payer mix is very heavily weighted towards those patients that have Medicare and Medicaid. So the reduction of Medicaid benefits has a direct impact on our patient population and our receivables. Those patients are not likely to need less services. Those patients still need health care. Everybody in the industry expects that the use of EMS to provide healthcare services is going to increase because we are the safety net. We show up 24 hours a day, 7 days a week, whether you have insurance or not. That is not something you find very common in primary care. So those patients that have chronic disease that are now not eligible for Medicaid, in Vermont we expect it to be about 45,000 or more. are going to have to seek their healthcare services from somewhere else. That being said, we sent out 3-year agreements to all of our towns, and you guys all agreed, and your rates are going to stay at 1% a year for the next 3 years, which is probably the only service that is going to stay at a 1% increase for the next 3 years. I don't know what the conversation is going to be 3 years from now. If anybody can predict what state, local, and federal politics are going to do over the next 3 years, I will gladly take that into consideration in my predictions. As of right now, what is exciting to me and certainly to our staff here is that we're in a position that we're going to be able to continue providing the service that you guys expect without having to significantly increase our rates for the next 3 years. So you asked, what are those rates? In anticipation of the legislation, as we watch the pattern across the country, as we watch state after state adopt 325%, in 2024, we raised our rates to match that 325% so that we can maximize the reimbursement coming from private insurance should one of the 2 states that we operate in adopt the 325%. I believe it likely that Vermont this year will follow suit with New Hampshire and become another state that adopts the 325%. So our rates are, if you look at our current rates, 325% of what the current Medicare fee schedule allows. Does that answer your question?
Yeah, I'm not sure what BLS and ALS mean.
Well, good question. So EMS is actually relatively straightforward when you think about the way that we bill things. So if somebody calls 911, it is most likely an emergency call, and what they will pay is $439 for that under the Medicare fee schedule. Keeping in mind, if it has Medicare, that 20% of that is your copay. So they reduce that number by 20%. So we get 80% of $439 is what we receive for Medicare payments. Non-emergency would be what we get for taking patients from one facility to the next facility.
Okay.
So we would get 80% of that number, which is why it's very difficult when we start talking about shutting down services in one place to the next and then having to rely on ambulance transportation to move those patients. In many cases, it is fiscally impossible to move those patients and not lose money. Ambulances that we are buying today are going to cost us somewhere in the $250,000 range, which means that we are spending somewhere between $2 and $4 just to put the ambulance on the road and pay for the mileage that it's between the cost of the ambulance and the cost of the equipment in the life cycle. Most of the time, we actually lose money moving patients, but we have to move these patients. ALS emergency would be any time that we have to provide advanced life support, so medications, IVs, intubations, a lot of the skills that, as you saw in the simulation earlier. Specialty care, transport, these are our patients, if you think of them like an ICU patient. So if we're picking somebody up at the hospital and they're on a ventilator, they have multiple IV drips running, IV pumps, that would be considered specialty care transport. They do pay better for that, which is good because they use up a lot of disposable equipment in those, and then you can see the mileage rates. But as far as EMS, those are really the only thing that we can bill for in our world. We don't, like hospitals, for example, they bill you for every individual line item. EMS, everything is bundled. So if the medication costs $200 and you get $400, then the $200 has to come out of what you got. So, great question. All right, so we're doing well. We're not immune from what's happening in the state, the region, and around the country, but we're well positioned to be able to hold our own for the next 3 years and figure out what happens. You guys are going to have stable service. We are very fortunate to have a very robust staff. We currently have a waiting list of folks to get in, so we are well staffed. And for the next 3 years, the new agreement started in July. every one of the towns is going to be receiving a 1% increase for the next 3 years. So you get a very stable rate, and I don't see anything right now that's going to change that. That being said, I want to make sure that it's on camera that I cannot predict what's going to happen in the current political world, and there may be a time where I have to come back and say, wow, I can't believe that happened, and we have to have a different conversation. But as of right now, today, there's nothing that we're seeing that is going to change our ability to continue to provide the service that you guys are currently getting. Questions? Comments?
How many miles can you put on an ambulance?
That is a great question.
For you.
So
And do you have to get rid of them at that point?
we don't have to get rid of them. So one of the things that we started 10 years ago, was an in-house fleet maintenance program. So a lot of services in this area get rid of their ambulances somewhere in the like 140,000 mile range. And a lot of that is due to the corrosion and stuff that's very typical of New England weather. So when we built our new Townsend facility, we started a fleet maintenance program. We have a full-time fleet mechanic. We've managed to stretch that interval out now to 250,000 miles.
That's great.
Is our target for the box style ambulances. The van, like you see outside, we're targeting about 185 to 190,000 miles with those. We'll see. So we have not, the transits that we currently have, we have not run any of them to the end of their service life yet. They're relatively new to us. If they're still running good at 180, then we will continue to see where that balance between maintenance and reliability kind of comes out. But right now, like I said, 180, 185 there, and 250 on the bigger trucks. Good question.
I did. I mean, when I look at and I'm sorry, I'm new to all this. You were charging $14.50. That was the rate, and if that wasn't covered by insurance, then the person was being billed.
Yep.
And now it's going to be so much less. I don't know. I guess that's just shocking to see.
Yeah, so it's challenging. So a lot of people don't understand how the billing component works. So there's a couple of things that are really important for people to understand. First of all, we have to bill everybody the same. So everybody, whether you are uninsured, whether you have Medicaid, Medicare, or Blue Cross, everybody has to be billed the same. That goes for staff and board members. It doesn't make any difference. Everybody gets the same bill. So that's number one. Number two is that when we bill Medicaid and Medicare, we're required by law to write off a certain amount. So you can bill them for whatever you want. I don't know how to do this. Oh, there it is. So you can bill them whatever number you want. So you can bill them $10,000 a call. However, they're going to pay what it is that $439, and the rest of it you're required by law to write off. So what'll happen if you were to, if I was to sit down and kind of go over our finances with you, is we have to bill the whole amount, and then we have to write off anything that Medicare. So it looks like your collection rate is very, very low because you have to bill a higher amount. But what's also in here is this is the total amount that you are allowed to receive. So that does not include the copay. So if you are a Medicare Advantage patient and you have a deductible, and say you have a $500 deductible, that means we'll get nothing because it's all within your deductible. And then that will go to your deductible, and the patient will be asked to pay that bill, but it will only be allowed to be billed up to the Medicare allowable. If you're a straight Medicare patient, then it'll be billed the Medicare, and then they'll pay 80% of it, and then it'll go to the patient as the co-insured. Or if you happen to be a Medicare patient that has co-insurance, then it goes to Medicare, and that 20% is paid by your co-insurance. If you're a Medicaid patient, the same thing happens. We have to write off Medicaid pays less than Medicare in both states. It's way better than it used to be. Right now, it's 3, 4, 5% less depending what state you go to, unless you're a Massachusetts patient, in which case it's like half of what Medicaid pays for. But there's no co-insurance currently with Medicaid. One of the changes that's coming, and I would have to look at the spreadsheet, the timeline, I think it's late 2026, is that Medicaid is going to end up with copays for ambulance service. It's not a lot, but there is going to be, as part of the big beautiful bill, is that we're going to lose money from the copays, and we do not collect a lot of the copays. Most people that have those copays don't end up paying those. When we build private insurance, so this is the 325% number. So historically, if we build private insurance, they would pick whatever number they wanted. And since we're such a small industry, there's no way for us to negotiate with them. So they would just pay whatever they wanted to pay. Sometimes they would pay Medicare rates, sometimes they would pay less than Medicare rates. And the only recourse we would have in order to try to get paid was to bill the patient. And then when the patient would call Ellen and say, hey, I just received a bill for $1,000 because my insurance didn't pay it, then we'd say, well, you need to call your insurance company and tell them to pay the bill. And usually, once the patient called, then they would actually pay the invoice. So the good news with the New Hampshire legislation is now they have to pay this number, and the patient doesn't get a bill. The other thing that happened in New Hampshire was kind of interesting is they did a study in 2024 looking at ambulance services across the state and what it would take in order for ambulance services to be financially solvent in New Hampshire. And what was different about the way they did it in New Hampshire versus the way they've done it in other places is it was done by the Department of Financial Regulation. In most areas, it's been done by the Health Department or Department of Public Safety. New Hampshire was done by the Department of Financial Regulation. And they looked at the expenses around, everyone's required to do an expense report, and the reimbursement, and determined that in order for ambulance services to be financially viable in New Hampshire, every payer would have to pay 202% of the current rate, including Medicare and Medicaid, in order to make everybody viable. So that's where they came up with this 325 number. And because clearly Medicare is not going to double their rates, Medicaid's definitely not going to double their rates. So what they decided to do is say, well, we're going to increase the rate for the private insurance to 325 to try to basically subsidize the fact that Medicaid and Medicare are not increasing their rates. And then we're going to readjust that in 2028 based on actual cost reports. Funny enough, the federal government did a ground ambulance study of their own, came up with almost the exact same number, that they would have to double their rates in order to make it viable for ambulance services to exist. I would be shocked if Medicare changes their rates for the better. But it's in the realm of mythical and possible. And so are dragons. Great questions. Any other? Yes, way in the back.
Can you talk a little bit about your subscription plan?
Yeah, good question. So the subscription program it's really unique to EMS. There's a special carve out in the law that allows us to have a subscription program. So for us, it's $60 per household. And the way that program works is we pool your money. So if you're a subscriber and everybody else is a subscriber, that money gets pooled and we have to use that money to directly pay your copays. It's a way that we can help to protect those people that maybe can't afford it. People that buy the subscription, that money gets pooled and it pays your copay. The part that a lot of people don't understand is we still have to bill. We're required to bill everybody the same. But if you are on that Medicare Advantage and you've got a $500 deductible, for example, we bill the insurance company and you're like, hey, we're not paying because you have a deductible. Then we take $500 out of the pooled money from the subscription plan. We move that money over, that pays off your deductible as if you had paid it yourself. And that's the way that program works. The invoice still exists, right? It still comes, but it's this kind of shared pool that money comes from. In order for that program to exist, that pool has to remain positive. So every year, Ellen has to keep track of all the dollars that go in, all the dollars that come out, and we have to make sure that we don't draw down that pool into the negative, because if it's negative, then it's discounting, and that's not allowed. So that's the way it works. So we set that rate per household in order to try to keep that balance the same. And I think in the next year, we're probably going to have to squeak the rate up, and the reason for that is Medicare Advantage. So we're seeing more patients that have higher deductibles because of the Medicare Advantage. We also may end up seeing people that were on Medicaid that end up off of Medicaid in the new system that end up using subscription plans. So I would not be surprised if you see the subscription program go up by a few dollars next year in order for us to try to keep that balance. Good question. What else did I forget to talk about? Any other? Yeah.
This is maybe too much into the weeds, but the ALS and BLS without transport is zero on Medicare. And
Yeah.
we know that Medicaid does step in with that, but we're not going to predict into the future as to how long Medicaid is going to step in on that, right? But I also noticed that paramedic intercept is also at zero. Is there some sort of tweak on that, or?
Yeah, so paramedic intercepts are not covered by any of the insurance companies. So you're only allowed to generate one invoice per ambulance transport. So if we are intercepting, for example, Deerfield Valley ambulance that's coming from Mount Snow and they need a paramedic, they're allowed to bill, but we cannot bill. You're only allowed to have one invoice. So we would invoice the service that we're intercepting for providing them that service. So we do have agreements with certain surrounding ambulance services to provide them paramedics when they need them. And that invoice goes directly to the service, not to an insurance company, because we're not allowed to bill insurance for those. And as far as the treat no transports, it is currently covered by Vermont and New Hampshire Medicaid at a fraction of the cost. So New Hampshire just passed their legislation. I think they now pay like $93. So Vermont is up to what's Vermont, 210? 200?
Yeah, it's
210?
279.
270, there you go.
Yeah.
So it's a challenge.
Yeah.
All right. I don't have anything else. That was the whole thing. Thanks for going easy on me.
Thank you.
Thank you.
I don't know if there's any food left, but maybe they still dessert.